the pre-lunch session. Almost it's like everybody in a different mood altogether. So there's so many things which are happening in everybody's mind. Basically, my topic is also something like that, which is going to deal with those things. What happens inside your brain when all these problems are happening? Can somebody just reduce the brightness of the lights, please? Those slides. Too much. Thank you very much, Charvas sir, for giving such a very nice introduction for my topic. It's actually, most of it, sir, has covered to make things easier for me for the presentation. It's been covered so much. Thank you very much, sir. Like, whenever we see some movies, like, we always think so much about the movies, how these movies happen, so many things. And there are so many scientific movies, science fictions, and all those things which we see. So nice to see, like, later when we get more insight, more knowledge into those things, mechanisms, we even start enjoying them once more, and we go back and try to see those movies again, to know them. So one of that two movies which I liked very much about these things, which involves a little bit amount of science fiction, is number one, The Phenomena. I think all of you have seen the movie, Phenomena, Don Travolta's movie, Phenomena. He suddenly gets immense knowledge, immense, learning capabilities suddenly. All of a sudden, he starts getting learning capabilities. He takes a book to learn Spanish. Within 2 hours, he has learned Spanish. A new language has been learned in 2 hours. Okay, so such is the capacity of the brain. The brain is it has so much capacity. The brain has so much capacity for everything. Other movie is what I just want to mention is the movie A Few Good Men, Jack Nicholson's movie, A Few Good Men, wherein a trainee, recruit, is taught discipline. Still that light is hurting me, please. A trainee is got in there, like, to punish him, they just gag him for a while and he dies. All of a sudden he dies after that. So that explanation goes, what is all those things? And then we come to say that, okay, probably there is buildup of lactic acid, which has caused him that. That goes towards like a condition called a mitochondrial disorder, which is possibly happening, all those things. So such type of things, it's in fact really happen. These are fictions, are actually not exactly fictions. In fact, such things do happen in our brain to cause all these problems. Okay. Charvas sir's topic has given a lot of insight into those particular events which happen, which we'll be talking about in little bit detail now. I'll be talking about in detail. Okay. So more of it will be like a story rather than a evidence-based facts presentation. I'm not going to quote any references there. I've combined all the literature to make it more like a story, so you can enjoy it in the pre-lunch session. So without mention of Robert Barney, no talk about vertigo and balance is complete. Who is the one who elucidated all the physiology, vestibular system physiology, when he was just 38 years old, okay, to get a Nobel Prize, right? This is most of the time our situation when a patient with vertigo comes to us. Okay, this is a situation most of us face when a patient with vertigo comes to us. When we see the appointment list, okay, list this patient, okay, this patient, okay, come for follow-up for this. This patient, I think 2 weeks back he came with vertigo, yes. What should I do? So, you are thinking, like, before you start treating that patient, when you're treating other patients also, you're thinking about that patient only. What question is going to come and ask me? Now, how I'm going to treat him? So, these things, right? So, one simple practical situations which most of us have faced, like, we have seen many people coming like with vertigo, especially vertigo when you talk about mens and all those things, after a long flight of 4 or 5 hours duration, the moment they landed in the airport, they're supposed to be taken to the hospital because they had a severe vertigo. I think many people would have come across such type of patients. After landing from the flight, they develop vertigo. So what exactly is this? How exactly does this happen? Number thing. Other thing, this headaches, suddenly all of a sudden. Sleep deprivation, I didn't sleep for 2 days. I'm getting a severe neck pain and I'm getting a severe headache. Okay, we don't know what it is, all those things. Okay. So now, to give answers to these things, some questions which we need to know. Okay, by knowing answers to these questions, we'll be able to answer all the events which happen. That's what's happening at the molecular level, which is causing the manifestations what we are seeing. What is happening at the molecular level, we cannot see by dissection. Only you have to use transmission electronic microscope to see that, okay, which most of us are not exposed to. What is the most important part of the cell? Questions which need to be answered now. What maintains the integrity of the cells? Integrity of the cells by mean to say the cell membrane integrity as well as the potential, the electrical potential integrity of the cells. What is that which maintains it? And these particular events, whatever we are developing called episodic events, like this Meniere's disease and migraine, most of the episodic events, are they life-threatening? And last thing, one thing, this NMDA receptor, N-methyl D-aspartate receptor, and the concept of excitotoxicity. What is this relation? Most of the time when Charua sir was telling, we give gentamicin injection, we give intratympanic steroid injection, we give gentamicin injection. Both of these work. Both of these work wonders when you're treating Meniere's disease. How is that? How this happens? So that is this NMDA. We're talking about is NMDA. What is NMDA is basically related to that. In physiology, Genong, when you joined MBBS, everyone told us, first thing is, you have to buy physiology textbook, Genong. Genong has to be bought. The first line what we see in Genong is this. Cells, there is intracellular, extracellular compartments, there is so much there. Fluids are maintained, intratympanic fluids, always in the intratympanic mood only. This intracellular, extracellular, ionic concentration, all those things. But the cells retain their integrity to water. The cells do not dehydrate. Okay, so much everything, intracellular, extracellular fluids, and yet permeate charged ions. This is the one which maintains the integrity of the cells. So these charged ions pass from inside the cell, outside that cell, intracellular, extracellular, through what is called as transmembrane proteins called as ion channels. These ion channels are the ones which allow the channels to go inside. What Srinivas sir was telling in the hair cells, they are partially open doors. The partially open doors, they become closed, they become full open. Those are nothing but the ion channels. Ion channels are the ones. So these are membrane bound proteins, all those things. They perform very key important functions. Okay. They are critically very, very important. These particular ion channels are critically very, very important when it comes to the excitable tissues, that is the nervous system. Any excitable tissue, the nervous system as well as the muscles, brains, everything. When it comes to the nervous system, they are very, very important structures, these particular ion channels. This we have to remember. So these particular ion channels, normally they are functioning all the time. Okay. So there were some amount of stress and all those things. Okay, like for example, what I told, any type of stress could be sleep deprivation, hunger, all those things. Okay, because of the stress and all those things, some amount of changes happen in them. Ion channels, they undergo some amount of changes. Though they undergo some amount of changes, they're very much capable of auto-regulation. Means they can regulate themselves to maintain the integrity. Some amount of regulation does continue to happen, maintaining the integrity normally. So these particular channels, ion channels, are two types basically classified. What is called as voltage gated channels and ligand gated channels. These voltage gated channels have very, very important structure within them called as the pore. Okay. We give the term alpha to denote this pore, alpha pore. They have this pore in the voltage gated channels. And next is the ligand gated channels, through which something helps them to do all those things. Okay. And as I was mentioning, this neuronal excitability is a very tightly regulated parameter, because a small voltage change there, okay, can result in so many things. Right. So all of them, it's like a series of like reactions what you get. All of them combined together, and one cell there's a change in voltage, correspondingly one more cell there's a change in voltage, corresponding all the cells there's a change in voltage, and there is an effective result. It's the first thing which is all that is important. If you have seen the movie Finding Nemo, the Nemo gets caught in the net. There are a lot of fish inside the net. Nemo uses one tactic. It says, we all can escape if we listen to one thing what I say. All of you start swimming down. So all the fish, instead of simply saying that, okay, we'll get caught, instead of getting confused, now all the fish, with all the power, one fish thought has spread to all the fish, and all the fish have started swimming down. So the fisherman cannot take the net outside, because there is so much energy which is pushing it down. It is something like neuronal excitability, something like that. With one cell doing it, all of them combined together, everything, and that action is it. And this particular expression of these genes, whatever I said, this ion channels, charges, whatever are there, they can undergo alterations and function changes are there. Okay, normally there's, but normally like one is little bit dysfunctional. Other channels, like say, like for example, if you say positive charge, there is sodium and potassium positive charge, negative charge is there. If one, there is usually some amount of dysfunction. Others usually compensate for that, so that you stay in a well compensated state all the time. People who have this channel dysfunction, where these functions do not happen properly, So there is very little safety zone for them for this particular alterations, the compensatory mechanisms to set in. It is because of this channel dysfunction, the safety zone is so less, they can get affected by this particular diseases. Okay. So what do you say? There's something, one dialogue which says about trouble. Don't trouble the trouble. If you trouble the trouble without the trouble troubling you, the trouble will trouble you. I am the trouble. It's something like that. Okay. So there is very small area for that. Like if you trouble it, 100% it will get troubled. Now we're going to look at what are those things. So this particular channel dysfunctions, whatever we see, they can be genetic and they can be acquired. Both type of channel dysfunctions are there. Since acquired is something most of them we see as a side effect of some drugs. We see when you take this particular drug, there's some alterations and you start developing some other clinical features. Okay, like for example, very common being, if you take antihypertensive medications, you start getting cough. So something like that. So there's acquired all things and because of some infections. And most commonly what we are seeing, these channel dysfunctions are post-dengue what we are seeing. We are seeing a lot of cases, complications of dengue. People losing vision because of dengue. People losing hearing because of dengue. People getting severe headache because of dengue. So acquired these channel dysfunctions. Okay. So these alterations in channels, they lead to this paroxysm of discomfort. So now by definition, coming to our topic, what we are talking about today, episodic neurological events. By definition, these episodic neurological events are manifestations of paroxysms of disturbed neurological function against a background of normal development. Structurally, everything is normal. You do MRI, it is normal. You do all the studies, most of the time studies will be normal. Investigations, most of the time will be normal. Okay. Most of the investigations, until we go to that level of molecular channel level, investigate. These events are something like that. And one thing which we need to keep in mind, just by going to this definition, which we have to be very careful about, is these events like can happen because of a structural problem also. So though the event is episodic, do not miss a major catastrophe. Always go in for imaging. A tumor can be leading to episodic neurological event. Okay, that's the most important thing. The most important features of this are, they're intermittent, they come, they go, they're recurrent, they come again and again. They're intermittent, they're recurrent. They're usually brief. Sir was describing drop attacks. They're usually brief, lasting minutes, 2 hours sometimes, headache and all things. They're usually asymptomatic between the attacks. That's the reason most of them, these particular people, they delay coming to the doctor. I had a problem today, tomorrow I am absolutely fine. I've taken one tablet of Vertin, I'm absolutely fine. So let me see, next week let I see the doctor, no problem. I'll take some time out of it, okay. So, and for every individual, there's a stereotyped symptoms. You see that? So that particular person, you see that stereotyped symptom, he will develop the same type of symptoms depending on his particular lifestyle. Depending on his particular lifestyle, same type of symptoms will be there. So you take a history, same symptoms again and again, probably you are dealing with episodic neurological disorders. And the question now is, why symptoms are classically paroxysmal when this particular lesion, channelopathy, is always there? That's what we are going to talk now. With this background, like it is there, channelopathy is existing there. Why? But why? Though it is constantly there, why it is this one? So going into the literature, going to the clinical features and all those things, 3 diseases, that is migraine, Meniere's disease and allergy. So comparing these 3 diseases, most of these diseases, so based on migraine, Meniere's and allergy, and most of the modules have developed. Okay, based on things. Because these 3 like occur cyclical manner, recurrent manner with similar changes. What has been seen, structural change, what I'm saying, similar changes. There's vasoconstriction, vasodilatation, and extravasation of plasma fluids in their pathogenesis. Also in an allergy also there is same thing. Excellent. So all this, there is association between these 3 things. So today we are going to combine 2 things, that is Meniere's and migraine, to explain how these episodic neurological events happen. So now, number 1, there's defective ion channel expression. So this leads to, like for example, because of channel, local increase in intracellular, extracellular potassium, and this leads to spreading depression in migraine, cortical spreading depression. And then this also thinks this osmotic disequilibrium, and which causes hydrops. Okay. So just one animation to show you, like, So we're talking about like in the brain, there are so many neurotransmitters and all those things. On the first slide, what you see here, the first image, there's so many neurotransmitters there inside the brain. So many neurotransmitters. We're talking about autonomic crisis, or autonomic system dysfunction, all those things. There's so many neurotransmitters involved there in the brain, which can get activated, deactivated with so many things. Okay. So normally, like in this, what you're seeing now, there is this ion channel, what are expressed there, that green things are the ion channels there. And the ion channels, they normally secreted, normally permeates ions and all those things. There's everything happen normally. Next, there are some antibodies to these ion channels. The blue thing, what you're seeing is called the regulatory proteins. The green thing are the ion channels. Okay. Sometimes acquired disorders or genetic disorders, where there's autoimmune disorders and other things, there are antibodies to these ion channels which come and bind to these ion channels. Yes, that is going to impair the function of the ion channel, number one. Sometimes antibodies to regulatory proteins also can develop, which is going to affect again. Okay. It is because of this reason, antibodies, you know that antibodies are suppressed by steroids. By giving steroids, this, if the problem is this, we have cured. We have cured the patient of the problem. But most of the problem is not at this level. There's further one more level of problem which happens. Other things, inadequate synthesis, like mitochondrial problems. They're not getting synthesis. The receptors are not getting synthesis at all, in which it's very, very difficult to treat. And defective mutations. These defective mutations, they are there, but they do not function at all. Okay. And next comes is what is called as the missense mutation. These defective mutations, there are nonsense mutations and missense mutations, which we need to know. A nonsense mutation is something which does not work. Whereas a missense mutation is something which works more. It starts working more. It's like a genie, which will come to you and tell, oh, give me more work, give me more work, give me more work. You cannot satisfy it. It goes on. So this is the basis for this missense mutation, the feed-forward loop. Unlike the feedback loop, the feed-forward loop, what happens? Which is very, very important in the disease which we are going to discuss. Okay. Coming to migraine. This migraine is a very, very special problem most of the times we see. And if the patient has headache, it's very, very easy to diagnose migraine. Yes, you can say very confidently, you can say, yes, this is migraine. Take one tablet and go. Okay, put you on this course. But if headache is not there, that's the most of the time we get a difficulty. So last time we were listening to a talk by Dr. Francis. Dr. Francis, I think, is coming tomorrow. Okay, excellent talk. What he described, the first manifestation of migraine in your life is infantile colic. If there is a history of infantile colic, definitely you are a migraineur. You have a tendency to get migraine anytime throughout your life. Okay. So migraine, you all know migraine with aura, migraine without aura. Okay. These prodromal symptoms of migraine, which we need to know, like they can very widely variable, hours to days together. Sometimes some people can have a prodrome of migraine before exact migraine attack comes. Okay. And 1/4 of these patients have an aura, and most of them it is visual. Okay. So this particular problem here in migraine is, this involves alterations in the subcortical aminergic sensory modulatory systems, that is glutamate, that influence the brain widely. Glutamate is a very, very important amino acid which is there, aminergic neurotransmitter which is there in the brain. So there's a lot of changes happening in this particular glutamate metabolism and all those things, which is responsible for the migraine. Okay. So when we go back, read the literature and all those things, we see that there is a problem. What causes glutamate problem is, there is a mutation, chromosome 19 mutations involving the CA2.1 P/2 voltage gated calcium channel. There's a mutation of this calcium channel. So what happens because of this calcium channel mutation? What is the further effects of this mutation? There is lot of glutamate which is getting released. So missense mutation, I told you, no? Missense, it goes on working more. Lot of glutamate is getting released. Okay, number one. And all this glutamate release at the cell level and in the synapse level. Okay, in the synapse, there is no metabolism happening at all. As glutamate transporters, metabolism is not at all happening at all, which lead to accumulation of glutamate these days. So glutamate has got accumulated there now because of a missense mutation of this particular calcium channel. That's the reason calcium channel blockers usually work in migraine. They do wonders, calcium channel blockers, Cybelium, they work very well in migraine. It's because of this particular thing. So glutamate has built up. Now what does this glutamate do? This is a question now. What is this glutamate do? So let glutamate build up. What is going to do? Please excuse me, I may take another 5 minutes extra than the time allotted to me. So large unmyelinated nerve fibers are there within the brain, coming from the ophthalmic division of the trigeminal nerve, which go around the cerebral vessels, the pial vessels, and the venous sinuses, most commonly the superior sagittal sinus. Lot of fibers are there. And also there are contributions from the upper cervical dorsal roots, coming into the posterior fossa. So these fibers, okay, these fibers are there. These go into the trigeminal nerve. These go into the trigeminal number 1. So this one, number 1, these so many fibers are there. So anything which irritates these particular things, okay, anything this irritates this particular thing, like for example, superior sagittal sinus I just mentioned, something causing superior sagittal sinus to get enlarged. Okay, like for example, during a premenstrual period, because of hormonal changes, it triggers that particular. So trigeminal nerve can get triggered. Okay, increased pressure, stress, anxiety, you're getting too much stress. Intracerebral pressure is increasing because of hypertension and all those things. So because of the blood vessels also innervations are there, it can get triggered. The trigeminal nerve ganglion can get triggered. Okay. And also another thing, because of this glutamate getting high, so cortical spreading depression, what we call the cortical spreading stimulation, causes stimulation of all this, that's like depression. So this one thing. Another things is like no sleep deprivation, your neck muscles, because of cervical innervation is there. Your neck muscles have not relaxed. It's only during deep sleep your neck muscles get relaxed. Because there is no relaxation of the neck muscles, the cervical stimulation also happens. So all these things come and stimulate your trigeminal nerve. Once this trigeminal ganglion is stimulated, it releases substance P and calcitonin gene related peptides, and very important thing, what's called vasoactive intestinal polypeptide. So this causes extreme vasodilatation now. There's a lot of vasodilatation. Okay. And along with vasodilatation, there's this feed forward reverse which is happening. Near the dura and all those things, near the sinus, all those things, it causes neurogenic plasma extravasation. That explains our severe headache in post-dengue, when there's so much of plasma extravasation happening in all the place in the body. Okay. So neurogenic plasma extravasation, the distribution of pain. Now, initially there was some vasoconstriction. Now, because of this vasoactive intestinal polypeptide, there is sudden vasodilatation which has happened now. Okay. So this vasodilatation happens, it's going to increase the blood flow. And once the blood flow increases, whatever this glutamate was there, okay, whatever the glutamate was there, this glutamate binds to this NMDA, N-methyl D-aspartic acid. It binds to that. So once this NMDA receptors, glutamate binds to this NMDA receptors, there's a lot of calcium which goes into the cell. Calcium enters into the cell. Normally this glutamate is plugged by magnesium. Okay. Now, when they are like, now what happens because of this? So much of sodium, calcium, everything going into the cell, and this hyperperfusion is going to cause what is called as excitotoxicity. Means the cell is going to get totally damaged now because so much of it going inside. And once excitotoxicity happens, the toxic free radicals, everything are released, and which cause the further damage. So it's a cascade which is happening. This is what exactly happens. Okay. So one very important thing is this glutamate binding to NMDA has been reported very commonly in cortical spreading depression. Okay. Right. So this particular thing, this particular response, what we talk about glutamate and NMDA things acting there, glutamate and NMDA response acting there. This one will also spread. It's also spread to the ears because it's all same thing in the circulation, everything, to cause endolymphatic hydrops very commonly. Okay. So now coming to the question of gentamicin. This gentamicin binds to this NMDA receptors. Okay, gentamicin is one thing which is going to bind to NMDA receptors, glutamate receptors, and it stops that actions. So this excitotoxicity starts getting prevented. Okay, the further damage starts getting prevented. And this is how it happens. So normally output what was very less, now we see the output is so much because of this particular thing. So we see so many things. What we need to understand is now, though there are so many stimulations, the primary problem with migraine is in the brain. This is a glutaminergic system which is problematic, which is causing all these systems. Okay. So along with medications, some lifestyle modifications, all those things have to be required. So that's what we avoid. Say like high glutaminergic diet has to be avoided in people with migraine, which causes this symptoms. Now coming to Meniere's disease, the second topic of today was Meniere's disease. How does it? And we have had so much discussion about drop attacks. I was so happy that so much discussion happening. Everybody interested in drop attacks and all those things. It's very good. End-stage disease, and somebody even got out a point that it need not happen only in end-stage Meniere's disease. It can happen within 1 year of Meniere's disease. Yes, exactly, it can happen. How exactly does that happen? So the inner ear fluids, we all know, we have been seeing like in MSc NTS, there's a 20 marks question. Luckily now the 20 marks has been abolished, only all 10 marks question. Okay, which says so much. Meniere's disease, etiopathogenesis, endolymphatic hydrops. Okay, this endolymphatic hydrops, the mechanism of inner ear homeostasis involves again ion channel transport, a blood labyrinth barrier, and a constant blood supply. A constant blood supply, a intact blood labyrinthine barrier, and ion transport system. Okay, we all know it is secreted by stria vascularis and all those things. Okay, marginal cells are there, everything are there which secrete all those things. And when there's endolymphatic hydrops, this is what you see. Endolymph is swollen up. The first image and second image, it's all swollen up. Okay, it's all swollen up. And this endolymph, whatever is secreted, it also gets absorbed. It's secretion, absorption, secretion, absorption. It's not static fluid. Secretion, absorption, all those things. Okay. There's this connective tissue, interstitial connective tissue, what we call, which is very, very important layer there, which is supposed to absorb the endolymph and the endolymphatic sac. Absorption happens to this particular layer. In this particular layer, there are some times when there is prolonged endolymphatic hydrops for some reason. Some hormones get induced. To mention, cordin, cochlin, and podoplanin glycoprotein. Okay, they are expressed in this interstitial connective tissue. For some reason, they get induced. Means the number increases. This cordin, cochlin, and podoplanin glycoprotein, the number increases. Once the number increases, okay, they go act suddenly at one shot on this particular endolymphatic sac, drain out all the fluid completely suddenly. So suddenly your ear is like, you just lose everything. Ear stops functioning all of a sudden. So that is going to probably explain why drop attacks happen. Because of sudden drainage because of the overexpression of this cordin, cochlin, and podoplanin glycoprotein, and which has been experimentally seen. This podoplanin glycoprotein expression has been seen, has been induced, and it has been demonstrated. Okay, sudden drainage of fluid. Okay, so this is all physiology. We have all spoken about this. Okay. So this endolymphatic sac, coming to the channel problem now, we talked about blood labyrinth barrier, this connective tissue and all those things. Okay. There are these epithelial sodium channels, which usually responsible for taking out everything. Whenever there is mutation of this epithelium sodium channel, experimental, it has not been demonstrated. It's not been demonstrated completely. Still trying to demonstrate whether this particular problem is there or not. This epithelial sodium channels, this mutation of this, I told you, voltage gated channels are something called as a pore. There's a mutation in this pore of the epithelial sodium channels which prevents, okay, which prevents that from draining. So that is the reason when there's channelopathies, the particular problem, you start developing endolymphatic hydrops. So one particular reason why you develop endolymphatic hydrops. So this also happens, like other than fluid, you have to also the salt content, the electrolyte imbalance and all those things, a number of everything, pores, everything. And how these things regulate ease at which fluid can flow through the endolymph and surrounding tissues. All the over time, what we call as fibrosis, recurrent infections, fibrosis because of infections, endolymph fibrosis. This also prevents because the tissue will not be at ease to release the tissues. So other channels which are very likely to be demonstrated, which cause change in endolymph and everything, is energy dependent sodium potassium-ACE channels, chloride uptake channels. So many other transporters are there which are responsible for things. And the sodium channelopathy due to alpha ENAC means epithelial sodium channel gene mutations might be a cause for pathogens of Meniere's disease, which by preventing reabsorption of endolymph. So endolymph gets accumulated. So though it is secreted normally, only it goes under and gets accumulated in plenty. So these particular people, they result in hydrops. In dissected specimens, what I have been seen, everything is that these particular people, they have hydrops. So what we say when we talk about Meniere's disease, probable, possible, okay, definite and certain Meniere's disease. Only after autopsy, you dissect and open, you see hydrops, yes, only then you confirm it as, yes, it is Meniere's disease. Okay, that's the thing. So now this particular endolymph, as you're talking about all this, is such a closed compartment. It's such a closed compartment. Things are so close inside. A 20 microliter volume change. 20 microliter when you're measuring in pipettes, when you're doing biochemistry experiments. We know that. What's the 20 microliter volume is? How much? So less microliters we measure in that pipette and take out that fluid. A 20 microliter volume change is sufficient to make the ear a hydropic ear. So yes, he is classified as hydrops. Now this hydrops manifesting with clinical features is Meniere's disease. Okay. So this particular people with Meniere's disease, now we see that all of them have a pre-existing hydrops. They have pre-existing eye drops because of the pathologies we have just described. Okay, they have pre-existing eye drops. Have lower threshold for intracerebral intraoral ischemia during the spells. They have lower threshold for intracerebral intraoral ischemia. So I'll just explain that second point. The unique attack characteristics arise because oral tissue show a different sensitivity to ischemia. So when morning physiological talk, we're talking about how cells act, everything. So different tissues have different sensitivity to ischemia. The hair cells, everything, hair cells of the vestibular system, hair cells of the labyrinthine system, everything, everything. All these cells have different sensitivity to ischemia. Each cell succumbs differently to ischemia. Because of this differential susceptibility to ischemia, we have the varied myriad of clinical features which develop. So what is this lowered threshold for intracerebral intraoral ischemia? What do we mean by that? So Starling resistor, the concept called as a Starling resistor. The fluid as such, this inner ear fluid, which is there inside, in a bony compartment, because this endolymph is there within the bone. So bony compartment is there, this inner ear is housed in a bone. In the bony compartment, so much amount of fluid is there, and this amount of auto-regulation keeps happening within these particular things. Auto-regulation in a sense, so whenever require of blood is more, require of blood is less, all those things have to happen here. So this, whenever there is endolymphatic eye drops, this particular, because of the distension, it impairs other things. It expands at the cost of the soft tissues. That is our interstitial connective tissue, the surrounding venules and all those things, the capillaries, all those things. Okay, it expands at the cost of that. So because it is expanded at the cost of those things, so the auto-regulation is stopped. There is no more auto-regulation happening in the ear. So because there is no more auto-regulation happening in the ear, now it can get succumb to any change in pressure easily. Okay, any change in pressure, it can get succumb to any change in pressure easily. So it's already marginally perfused and there is eye drops, and because of which it can get changed to any pressure changes, like for example changes in atmospheric pressure. Suddenly there's a change in atmospheric pressure. As I was mentioning about in the flight, you have traveled all the way in the flight from one place to other place in a different altitude, a country with a different altitude. Okay, here in India you were there, you went somewhere, some other altitude, you landed there, the altitude is different. Yes, suddenly there is a change in pressure, atmospheric change in pressure. Okay, that is the basis of your Minniet's device, which tries to equalize the atmospheric pressure from outside to inside. Intracerebral fluid pressure. Okay, CSF pressure, change in CSF pressure. Like most commonly, we're talking about autonomic reflexes. When you're standing, most of it, there is fluid is in the legs. When you're lying down, when the head is down, the fluid start going inside. Head pressure increases. And state of hydration, your hydration level, your other salts, your fluid levels, everything what you're taking. So all these things expose your ear whenever there is a changes, these particular things. Suddenly it starts, this particular whatever is there, Starling resistor, it fails to work, and once it fails to work and you start getting problematic, and then it tries to compensate for that. So it tries to get back blood because there is ischemia because of all these things. It tries to get back blood and there is reperfusion which is happening. And once reperfusion happens, I have just explained how things happen. There is this glutamate binding to NMDA and all these things, problems which are causing. I hope I have told a nice story. Yes, sir.